Welcome back to the Stat Dose podcast. It's Matt and Joe again. We're doing another turbo dose, and today we're going to be talking about pulmonary embolisms. So we're just going to go through the overview, a bit of pathology, looking at the features, how we're going to assess and manage these patients, hopefully to help in simulation and in practice.
So there's a quick overview for pulmonary embolism. In terms of the pathology and what's going on for these patients, a pulmonary embolism is essentially venous thromboembolism that has become trapped in the pulmonary circuit. In terms of the risk factors for these patients, they're well documented in the Wells score, which you can access through free online tools like MD Calc. Risk factors very much include those that are classically set out in Virchow's triad. So that of conditions which provide you with endothelial injury, those who are at risk of blood stasis, and those who are hypercoagulable for whatever reason. Most PEs are due to a deep vein thrombosis in the lower limb, and so you want to be looking at this as a huge risk factor in the setting of a short of breath patient with chest pain. We want to be checking those, doing those peripheral assessments, having a look for that unilateral hot red tender calf, ankle, thigh area. If you were to round off some of the key features, what would they be?
So number one, probably pleuritic chest pain. So pain's worse on breathing. Shortness of breath. It's often exertional shortness of breath, but you may get it at rest as well. A history of collapse is a bit of a red flag feature. That's going to be suggesting essentially quite a large clot. It's something that's causing obstruction, causing you to become hypotensive. Hemoptysis, again, is not a massively common feature that I see, but it is there on the Wells score. Obviously, if there's evidence of a lower limb DVT or a known DVT, as you were mentioning there, Joe. But one of the key sort of irritating things, I suppose, is that they may be asymptomatic. So you might not have any features at all, which obviously makes the diagnosis a little bit more difficult. And then moving on to examination, the larger PEs, you're going to have patients who are hypoxic. They're going to be hypotensive. They may well have a raised JVP. They're likely to have a raised respiratory rate, and they might have a tachycardia as well. But again, in examination, there may be no features to suggest a PE as well. Again, just highlighting how it's such a difficult diagnosis to make in lots of our patients.
Thinking about the assessment then, one of the things that we absolutely want to be doing in all of our patients who are short of breath with pleuritic chest pain is undertaking an ECG. We're looking for evidence of right heart strain. Classically, the teaching is the S1, Q3, T3 pattern on an ECG, although actually the likelihood of seeing that is very low, and the most common signs that you will see on an ECG and the most common finding is actually simply a sinus tachycardia. So alongside that, alternate findings might be incomplete or complete right bundle branch block alongside a right axis deviation. And then sometimes we can also see T-wave inversion and ST depression in V2 and V3.
Yeah, chest X-ray often won't show anything particular for a PE, but you might sometimes see a bit of collapse if it's a large PE. But the chest X-ray more often than not is clear, and actually you're largely doing the chest X-ray to look for other causes. So if there's a big pneumonia there or a pneumothorax, which could give these equally sort of pleuritic type chest pains, could cause a bit of hypoxia as well. So you're largely doing a chest X-ray to look for other causes rather than to look for a PE. But really the key imaging that we want to do is the CTPA. And there's quite a good decision-making process that is used by NICE. So essentially, if you're considering a PE in your patient, you're going to complete a Wells score. Again, have a look on MD Calc or other such tools just to find the Wells score. If you've got a low Wells score, i.e. you think a PE is unlikely, then those are the patients that we're going to take a D-dimer for. And so if the D-dimer is negative and you've got a low Wells score, it's not a PE. So look for other alternative diagnosis. If you've got a low Wells score, i.e. less than 4 with a positive D-dimer, then that's somebody you're going to want to anticoagulate, bring into hospital and do a CTPA for. But if you've got a high Wells score, so a score above 4, there's no point getting a D-dimer. A positive or a negative D-dimer cannot rule out a PE in somebody if you've got a high Wells score. So those are patients you need to get CTPAs on. And obviously, if that's if that demonstrates a PE, great, you're going to bring them into hospital, you're going to start some anticoagulation. If that's negative, then that doesn't definitively exclude a PE. So I think from memory, it's about 97% sensitive. So it does mean there's 3% of patients we're missing. And those patients, we often will do repeat imaging in around a week. That may well just be an ultrasound of the lower legs. It may be a secondary CTPA if the clinical suspicion is high.
So talking about the classification, going from the top and going from massive PE, there's one that would cause an obstructive shock. Those patients that are exceptionally unwell, and they're going to be those patients that you need to make immediate interventions in. So these are patients who are shocked, typically with a systolic of less than 90 or a drop in their systolic blood pressure of over 40 milligrams of mercury over 15 minutes without an alternative explanation. So thinking about the other reasons as to why you would have a hypotension. Submassive PE, alternatively, is where we do see some of these features of PE, and on top of that, there is evidence of right heart strain or myocardial injury. This is in contrast to the non-massive PE, or what used to be called our sort of low-risk PE, and a number of different terminologies. And this is where we suspect a PE, but there's actually no evidence of the submassive or massive PE categories. What do you do in the emergency department for these individuals? Because essentially, once this is diagnosed from our offices, they come to you.
So A, B, C, D, E again, sounding like a broken record, but that's what we do. You're going to want to make sure that you're correcting those abnormalities as you find them. So hypoxia, obviously give them some oxygen as much as they need to get into their target saturations. These patients will often benefit from fluid boluses. So if you do have a PE causing a degree of obstructive shock, a little fluid bolus might just help with that venous return. Make sure that they're analgesed well, obviously. These can be very painful, so make sure your patient is comfortable and able to take deep breaths in. And once you've gone through that sort of imaging process that we talked about earlier, if it's a confirmed PE, then our modern day first line is apixaban or rivaroxaban. You can use low molecular weight heparin while starting warfarin if the patients opt out of using apixaban or rivaroxaban. The other key sort of management that we can start in the emergency department for these patients is thrombolysis. So thrombolysis is indicated for a massive PE. So as Joe mentioned, that's somebody who's shocked, so systolic less than 90 or that drop of greater than 40 over 15 minutes. And thrombolysis, again, you can use in the peri-arrest patient or your arrested patients if you think that they've got PE. If you thrombolyse somebody who is arrested, you do need to continue CPR for at least 90 minutes because that's how long the thrombolysis takes to completely work. And there is some growing evidence that actually the submassive PEs may well benefit from thrombolysis, but that evidence is still ongoing, so there might be a change in practice over the next couple of years.
So that's just a brief overview of pulmonary embolism in terms of the pathophysiology, the features, signs, symptoms that you will see. Some assessment findings. We've talked about the classification in terms of the massive, submassive and non-massive PEs. And we've talked about management. And hopefully this will guide you within the realms of pulmonary embolism